It's my distinct pleasure to introduce our uh, Ribinar speaker today. Dr. Ali Abbasi is a consultant musculoskeletal radiologist from London. He started out as a surgeon. I think he's going to talk to us a little bit about that, so I'll skip that part. But he has a practice that's really focused almost entirely on chest wall imaging. We were lucky to become acquainted with Dr. Abbasi a couple of years ago, and he is one of our one of our few radiologists. We're hoping to gather more, but he and CWIS have developed a friendship and some collaborative work, and we're just delighted he's here today to make us a little smarter about ultrasound. Ali, take it away.
Thank you, Tom, and thank you to the Society for the opportunity to talk to you this evening about this topic. And I wanted to just tell you a little bit about myself, not from a egotistical point of view, but I thought it might just give you a bit of context as to how I ended up here, because it certainly wasn't my career aspiration when I started out to end up imaging the chest wall. But my passion in life was to be a surgeon, and this is what I did for the first part of my career. I qualified and then undertook surgery, and I fell in love with cardiothoracic surgery, believe it or not, in spite of everybody telling me otherwise, or telling me not to do it. But I just couldn't get rid of the bug. But after some time, and due to some political things in the UK with cardiothoracic training and some fortuitous or unfortuitous events, I ended up making the leap to radiology. And those are my two daughters, who are now much bigger than that. That's years ago. And I became a radiologist. And in my training, I moved to musculoskeletal radiology. And I never thought that any of my knowledge from cardiothoracic surgery or operating would ever come in handy. And it really didn't for many, many years until around about 2019, where one of my very esteemed colleagues called Ian Hunt, who I'd known when I was a trainee because he was a very eminent thoracic surgeon, but never met him in real life. He gave me a call one November morning and said that he had been seeing these patients with musculoskeletal pain in the chest wall, but that he'd been doing lots of imaging in those patients with CTs and MRIs, and they could never find a cause for it. And so he asked if I would be interested in imaging some of these patients. The chest radiologists that he was working with were predominantly interested in looking at the lung parenchyma and looking at the cardiovascular structures, but not so interested in looking at the chest wall. I admitted to Ian at the time that I'd never really done anything like this before. I'd done ultrasound of the chest wall in the context of, or the chest in the context of looking for pleural effusions and sighting drains, but never really looked at the chest wall. And it then, through my reading, emerged to me that no one had really done very much of that before, and I was really very much in the dark. But it was Ian's handholding that really helped me through those early days, and all of that cardiothoracic knowledge that I thought had been confined to the history books really came flooding back. And the advantage of having performed a thoracotomy myself and done a sternotomy myself and lung resections and chest wall reconstructions really came in so much use as I started imaging the chest wall. I wanted to take this time now to just spend a little bit of time talking about the principles of ultrasound, because I think I'm going to bore you for the next few minutes just talking about principles of how ultrasound works, because it will then emerge why this became a really powerful tool. I'm definitely not a radiologist that tries to have a sort of a fight between which is the best modality. I believe that you should use all the modalities and use them all for their strengths. But ultrasound is particularly advantageous in the chest wall, and that will become clearer as the presentation goes on. But the principle of ultrasound is that there are materials in the world which are called piezoelectric effects. So people pronounce it differently. It could be piezoelectric or piezoelectric in materials. But these are basically materials that when you pass a current through them, they will expand and contract, and that will create a sound wave or a hypersonic sound wave. And if an alternating current is applied to the disc, then the disc will expand and contract with the same frequency as the current. Each wave moves along by the distance of a wavelength, which has got the wavelength symbol, and the frequency with which compressions occur pass a fixed point at the same frequency as the vibrations of the transducer. So this is basically the structure of an ultrasound probe. Have I got an arrow? I have. This is the piezoelectric disc. The current passes through. You have an epoxy resin backing block, which essentially provides an insulation and ensures that the sound waves that are coming back from the disc are transmitted through that. And then you have a matching block or matching plate, which is the plastic surface that touches the patient's skin. I'll explain later why that's really important. And then you have an insulator and a metal outer casing that sits on the outside. So just a few basic terms. Axial resolution is the ability to distinguish between two structures that are located in parallel beam. So if you had two vessels, for example, one more superficial than the other, then axial resolution is the ability to distinguish between a vessel and, for instance, I don't know, a lesion underneath that vessel. And that's equal to half the spatial pulse length. And spatial pulse length is the product of a number of cycles in a pulse of ultrasound and wavelength. And the wavelength is determined by the operating frequency of the transducer. So just bear that in mind. I'm not going to go too much detail into the physics of it, but let's just keep those basic terms in mind. Now, the lateral resolution is high when the F is long. So that's the near zone. So the near zone is when the ultrasound sound waves will produce the highest resolution image in the near zone. And then beyond that near zone, the sound wave diverges and becomes the far zone. And so any information that's being retrieved from this area will be of lower resolution. Now, using this mathematical formula, the take-home message is the higher the frequency of probe, the longer your near field will be. However, the trade-off is that near zone of higher frequency probes are smaller. So putting that together, if you use a high frequency probe, you will produce a really high resolution image, but you will not be able to go to very much depth. By contrast, if you use a low frequency probe, like for example, 6 to 8, 10 megahertz, then you will have greater penetration of the soft tissue, but your resolution will be worse. You can focus that focal zone. So there is a focus, a bit like you would have on a camera, where you can focus. So if you're looking at structure at a particular depth, you can focus the sound waves so that your maximal resolution will be in the focal zone, not just looking at the structures that are just in your near zone. Now, just bear with me on this one. The acoustic impedance is the stiffness, depends on the density and the stiffness of a material. So this is what determines how the sound waves behave as they travel through different tissue types. The velocity of sound waves is fixed through certain structures. So through soft tissues, it's the fastest, but through air, fat, bone, these are very predictable velocities of sound waves through these structures. And really what determines how much of sound waves are reflected back are determined by the differential of acoustic impedance. Okay, so the reason why this is important is if you were to just place the piezoelectric disc, that you pass the current through directly onto soft tissue, then the reflection coefficient is 80%. That means that only 20% of the sound waves are reflected back. You just don't get enough data. But if you put a matching plate, which is somewhere in between in terms of the reflection coefficient of the disc, of the piezoelectric disc and the skin, then that improves the transmission. And then if we add a coupling agent like a gel or oil or ultrasound jelly, then that improves because the reflection coefficient of gas to soft tissue is 99%. If you remove any gas, which is what you're doing with a coupling agent, then you will improve the sound transmission through to the probe. So no more physics. That's it. That's why ultrasound is very good. But the main advantage that ultrasound has over CT and MRI is that it has better temporal resolution. That is to say that you can image in real time. When you image with CT and MRI, one of the big problems we have, particularly when imaging the chest wall, is that one is breathing throughout the whole thing. Now in CT, one can overcome that because CT is so fast that you can do the entire scan in a single breath hold. With MRI, that becomes much more challenging because the scans can take anything up to about half an hour. Each sequence that you acquire can take between 2 and 3 minutes. There are faster sequences, but even those, some of which you can do during breath hold, and they are improving MR imaging. But nonetheless, the big issue with the chest wall is there is lots of motion. and that can really impair the resolution of the image that you acquire. Ultrasound, by contrast, is not affected by that because you can image in real time, and therefore breathing motion artifact is less of an issue, lung motion is less of an issue, and so on and so forth. So the temporal resolution of ultrasound outperforms CT and MRI, and that is particularly advantageous when looking at the chest wall. And what I wanted to do now is to tell you, well, there's been a dramatic rise in the interest of imaging of the chest with ultrasound. You can see that these are the number of papers that have been published over time. These have been done for a variety of reasons, though. People are used a lot of ultrasound during COVID to assess for pleural pathology, pleural movement, sighting of chest drains, diaphragmatic motion, a variety of different applications using ultrasound chest as the tool, and that's taken a sharp rise. The other thing to note about these papers is the number of papers that are talking about examinations being performed by non-radiologists. The massive upstroke since the advent of fast scanning. Sports medicine have taken up ultrasound massively. So ultrasound is becoming increasingly a tool that's not being done by radiologists, but actually being done by clinicians who are able to do something called point of care or POC ultrasound by the patient's bedside, rather than relying upon the radiologist to do that. This is particularly advantageous in things like rheumatology, where the rheumatologists are now doing scanning by the bedside or in clinic, looking for synovitis, and can make decisions about treatment there and then in clinic. So it's very, very advantageous once the clinicians are able to acquire that skill. But I want to show you some cases now of things where ultrasound has been particularly advantageous, and the big one would be trauma. This is a very sort of recent paper that's just come out in the last 6 months, published from Greece, which was an observational study which compared ultrasound against CT using multi-detector CT as the reference point for looking for suspected rib fractures. These were all performed by a single operator, which was a non-radiologist. It was performed, I think, by a sonographer, but the images were analyzed by a radiologist. And I was quite interested to see that the machines they used were actually not particularly high-performance machines. These were GE machines that were operating at frequencies of 6 to 12 megahertz. That's fairly standard, available in most hospitals, in addition to a mobile handheld pad, which I have used, and they are okay, but sorry, it's echoing a bit. But they're certainly not as good as the high resolution machines that one would find in a radiology department. And in this paper, in this study, there were 59 patients, and as you can see from the data, the sensitivity of ultrasound was significantly better than using chest X-ray. And I don't think that should surprise many of us, because chest X-ray, if we look at it, it's mostly automated these days in terms of the parameters when acquiring the image, but all of those parameters are optimized to look at the lung parenchyma and the cardiovascular contour, and not so much the ribs. The ribs sort of come for free. We say they come for free, but the image is not optimized to look at the ribs. And therefore, whilst one might be able to see the ribs, one is also able to see the liver on a chest X-ray and also able to sometimes see the spleen on it, but we wouldn't use that as the first line investigations for looking at those structures. I would argue that when we look at the ribs on a chest X-ray, that's not the primary purpose for what we're looking for, or not the ideal modality. And so ultrasound in this particular study was shown to be significantly superior to the plain radiograph. And why is it so? Well, here's a really nice image of why ultrasound performs so well when looking at the chest wall, and that's because it has very, very good soft tissue resolution or contrast resolution in the chest. This is a really nice representative image because there's multiple different structures here. This is the costal cartilage, and we can see the costal cartilage very well because the sound waves do get through, and therefore we're able to see the superficial surface and the deep surface of the costal cartilage. We're also able to see the perichondrium, which is this thick line of bright line that goes on the upper and inner surface. Contrast that to the rib, which is the bony part of the rib. So when I speak to Ian, I talk about the rib in two parts. There's the costal cartilage and, of course, the rib. So if I say rib, I tend to mean the bony part, and the cartilage I'll refer to as cartilage. Underneath that, you're able to see the pleura. So this is the lung. And then you'll see that there's no sound. The sound does not get reflected back very much beyond just the superficial aspect of the lung because the sound doesn't transmit and does not reflect back to the probe. And so the probe fills that information in with blackness. Similarly, the sound waves reflect almost completely from the rib surface, from the bony surface, and therefore no sound waves get deeper to the rib. So you can see the costochondral joint very, very well here, much better and higher resolution than we would do on other modalities. Lying superficial to that, one can see the pectoralis major muscle, which has this very characteristic streaky appearance that muscles have, and then the subcutaneous soft tissues. So looking at this, one can see that actually we have very high resolution images of the cartilage surface and the bony surface of the rib. And therefore, even subtle deviations from that become very easy to see. So this is a patient who had a rib fracture, a very subtle rib fracture. This is a high performance athlete in motor racing who sustained this injury, actually had a CT and an MRI. The CT didn't show anything. The MRI, which I don't have available, I would love to have shared it with you, but the MRI just showed a little bit of bone edema, but nothing much else. But in the ultrasound, you can see very clearly that there is a cortical irregularity. In fact, you can see the cortical break. One can see the slightly raised periosteum at this site, and you can see the very small subperiosteal hematoma, which when you put vascularity on has a little bit of hyperemia. So in this scenario, it does make a big difference in this particular individual because one was able to diagnose the rib fracture and then be able to plan future management, which you wouldn't have been able to do on the additional modalities that were required. This is a really interesting case. These are two studies of the same patient 3 weeks apart. So this is a patient who works as a diplomat in London. And sorry, can you just mute the other participants at the moment, Sarah? I don't know. It's just, there's a feedback coming. Can someone just mute the other participants? Anyway, we'll carry on. So this patient arrived having played football. He was elbowed in his chest while he was running and immediately noticed pain and noticed a deformity in his chest wall, which he could palpate, and it was very sore on the left side of his chest. He left it a couple of weeks and then went and saw a thoracic surgeon who organized for him to have a CT scan. And this is the CT scan of the sixth cartilage and the costochondral joint. And really, this was looked at twice by two different radiologists, and I think we'd all agree that that looks essentially normal. But the ultrasound a week later looked like this. Now, I'm not saying that this was missed, and it's possible that this has displaced in the 1 week interval, and I think that's probably the most likely explanation. But I think you'd be hard pressed to find any injury here at all, even if that was an undisplaced injury. The CT really undercalls and really doesn't pick up on anything. And this has now been looked at, as I said, by myself and two other of my predecessors who are all very experienced musculoskeletal radiologists. And even with the hindsight of doing that ultrasound, one cannot see anything really pathological in that rib when actually there is quite a significant injury. And this patient actually had two rib fractures. The fifth and the sixth costochondral joints were both injured. The other advantage that one can have a look at is the actual joint itself. And ultrasound, as I mentioned to you earlier, doesn't have the same problems that CT and MRI have, which is that you have to have a static image. And this is a patient who's had a costochondral joint injury, which you'll see. And on ultrasound, one is able to see the motion within that joint. There we go. You can see that open out. This is a patient taking a cough. Bang. There's the joint opens up. The other things to note here is the perichondrium is raised. There's a subperichondrial hematoma here. In this case, what's very advantageous is the perichondrium isn't torn. So we think that's going to be a good prognostic indicator that this should heal. This is the pectoralis major overlying this. This is actually the first costochondral joint on the left side for this patient. Again, I'll play that again. When you ask them to do Valsalva, you can see the joint open up very, very clearly. I don't think you would see that on a static scan because this is the resting position of that joint. So it'd be very difficult to illustrate that. That's that one. This is the first costal cartilage injury on the right side. Now, the first costal cartilage is very difficult to image on any modality, even on CT. It can be quite difficult to illustrate any pathology in that region, but ultrasound is actually really nice. One is able to get into the plane of the first cartilage. As you know, it has a very unusual plane. It's slightly deeper to the other cartilages. It's really tucked in underneath the clavicle. But with the probe, one can really dig in and get a good view of that. And in this particular case, you can see that there is quite a significant injury here of the first costal cartilage. This is the you can even look at the synchondrosis joint. So this is where the first costal cartilage joins onto the manubrium. As you know, the first cartilage forms a synchondrosis, unlike the other costochondral joints. This is a very, very strong joint here. It's, as I said, it seamlessly blends into the bone, and hence it's more of a synchondrosis than a costosternal joint. But the fracture here, you can see very clearly, creates an offset of about 3 millimeters. And when we do a dynamic scan, again, we can see the motion in that. Again, on the CT and the MRI, one might not see the motion, but here on the ultrasound, one can see that with Valsalva, there is motion within that. The other thing that one can note are the additional injuries. So unlike the previous study I showed you, there is actually a tear of the perichondrium here. And you can see that there's soft tissue changes that are extending into the pectoralis major on this side. There is a hematoma as before, and one can see that there's quite a lot of soft tissue damage at this site, because indicating that this is a much higher energy injury than the one on the contralateral side. Show you that again. This is being stressed, and there you go. You can see that open out. Ultrasound is also very good for looking at other soft tissue injuries. So this same patient had a previous pectoralis major tendon repair, and you can see that repair is intact. So at the same time, one is able to just slide over the chest and look for any other injuries at the same time, not having to rely on anything else. But if the patient says, look, I also had that, can you have a look at this other thing as well? One can just slide over and assess that. This is a really interesting case that I want to share with you. This is a patient who's very overweight. Funnily enough, he's actually quite an active man, plays golf very regularly, and actually engaged in Pilates, but a very large pendulous abdomen, and sneezed very hard during a very severe upper respiratory tract infection. That led to a rib fracture. Now, that had been characterized on the CT, which I'll show you. He went on to have a CT eventually, and that showed the costal cartilage, the rib fracture, the lateral rib fracture, and that was demonstrated on that CT. But this gentleman continued to have pain after several months. And the bit that was missing, and this took some time for me to really get my eye in, is if you look at the normal side, what you see are the ribs on the right side. So this is the 8th, 9th, and 10th ribs. You see the external oblique muscle going over the top, and these are the intercostal muscles here. And on this side, that's missing. There's a big defect, and the soft tissues are caved inwards, so they're very convex here. And there's a big defect measuring about 6.4 centimeters in that muscle. And what the subsequent review of those old CTs show, and this is a 3D reconstruction, I'm not sure how well this is projecting, but these are the external oblique muscles on the unaffected side. And you can see that there's a large defect on the right side, which is where this tear has occurred. But actually, this is that rib fracture, and he's actually got a costal margin rupture at this site. And this is all missed on just the CT itself, because no one had done the 3D reconstruction. The scan had been reported by a chest radiologist who found the rib fracture, but not much else. So this is where the ultrasound was extremely advantageous in picking up that injury, and looking back at that CT and reconstructing them. You can see that the injury is there, but perhaps one might overlook that once they've found the rib fracture. The other advantage of ultrasound, of course, is dynamic ultrasound, and this has been particularly advantageous in the world of slipping rib, which, whilst many people still believe that the diagnosis is made clinically based on patients' risk factors and some of the history that they give, I would beg to differ, and hopefully we'll be publishing some of our data in the near future showing that we think that ultrasound is superior to a clinical assessment. And of course, this is me doing a dynamic ultrasound. Oh, sorry. Why is that not playing? Oh, it's not playing. Sorry, that should be playing. I don't know why it's not playing now. But that's me performing a dynamic ultrasound on one of the guys that work in my clinic. And the advantage of dynamic ultrasound is that one is able to have a direct interaction with the patient to identify the area where they have discomfort. We have the ability to perform a number of dynamic maneuvers, which unfortunately I'm unable to demonstrate here, but one is able to get them to do particular maneuvers such as axial rotation, abdominal flexion, forward flexion. We can get them to do various dynamic maneuvers such as Valsalva-ing, etc. And all of those maneuvers allow us to make an assessment of how cartilages move. But really, for us, one of the most advantageous things has been able to do is, rather than just being fixated on watching ribs slip, is the ultrasound images are so high resolution, we can actually see whether that's actually impinging on the intercostal neurovascular bundle. And this is an example of a patient who does indeed have slipping. And you'll see that this is the 10th cartilage. The
Ante,
patient is performing. Yeah. Say again.
sí, pasa.
Sorry. Sorry. Okay. This is the 10th cartilage, which you'll see will slip underneath. But the key thing to note in this scan is that at no point does the cartilage actually compress onto the nerve. So in this particular, you'll see here's the 10th cartilage, then the intercostal space. I'll try and pause it at the right moment. There. You'll see that the intercostal space is actually always maintained, even though the rib does do a slipping motion. So just seeing simply a cartilage slip doesn't necessarily mean that it will be symptomatic. So you can have slipping rib, which is asymptomatic. And this is a good example of one where a patient does actually have slipping. But in this particular event, the patient does not compress the intercostal neurovascular bundle. But of course, ultrasound also allows us to see lots of other things, and lots of surprising things do come up when we're scanning. This is a patient who presented with rib pain for a number of years. We had performed the dynamic scan. He hadn't slipped. He didn't slip at all at any level. He presented with slipping rib. But actually, when you scan more laterally, what you found is in the intercostal space, there was a rounded lesion that was present. And on subsequent MRI, that was shown to be a schwannoma. So this patient actually had pain from a nerve sheath tumor, which was causing his discomfort, not the slipping rib or the lack thereof. This is a patient who presented with an increasing size lump, was diagnosed with costochondritis, left it for some time because she thought it was costochondritis. GP had told her to just, primary care physician had told her to take painkillers, which she had done. But she eventually presented to us. And actually, she had this very large intraosseous lesion within the manubrium, which is expansile, and it had intraosseous, it had hyperemia. And with my other hat, because I have another hat, which is interested in imaging in myeloma, very quickly, I thought that this looked like a plasmacytoma. And indeed, that's what this turned out to be. This was a plasmacytoma of the manubrium, when these diffusion weighted sequences show that there is diffusion restriction, because this is a very cellular tumor. So it will restrict the diffusion. And you can see that there. So the patient then went on to have treatment for multiple myeloma. And then this is a case that's very hot off the press. This is a patient that was diagnosed with costochondritis for about 18 months, came with left parasternal chest pain, which is the bit that was tender. And as I scanned, our conversation became very quiet very quickly as I identified this soft tissue lesion, which was hyperemic. The patient was diagnosed then with a fibroma, which I was a bit surprised as a diagnosis, and the patient was going to have cryotherapy for it, but someone thought to biopsy it just before they went on to do cryotherapy, and actually it turned out to be a breast cancer. So this patient is now undergoing treatment for breast cancer. So that was a quick that was a very near miss. Funnily enough, costochondritis is a diagnosis I make very infrequently, and that's because on the ultrasound I can look for signs of inflammation. And this is one of the very few cases in my whole cohort. 0.8% of my cases have turned out to have costochondritis, but this is a case where the patient does indeed have costochondritis. And what is it that I'm looking for? Well, do you remember that perichondrium that I pointed out on the ultrasound? Well, compare the same rib. This is the second costal cartilage on the unaffected side. This is the affected side. One can see that there's this increased echogenicity, ill definition of the cartilage, and when one places vascular or microvascular imaging on, we can see that this soft tissue is hyperemic. When the patient went on to have an MRI, you can see that there is edema on these diffusion weighted show it very well. That shows that there's very clear-cut edema in the perichondral soft tissues. And again, you can see that there is edema above and below that second costal cartilage and some reactive edema within that adjacent manubrium. So the reason I call this lecture the ultrasound being the stethoscope of the clinician is because this is the stethoscope that was introduced by, now I need to see how to pronounce this gentleman's name. He's a French physician called René Laennec. And he had to examine a young lady, and the way that people would auscultate the chest in that era would be to place the ear directly onto the chest. And he found that a bit embarrassing in this young patient, and able to auscultate just as well. Well, the stethoscope is now really the symbol of doctors. I guess if you see somebody walking around with a stethoscope, it's very difficult to imagine that they're anything, or certainly most people would assume that that individual is a doctor. And the stethoscope the Greek word origins from stethos, which is the chest, and scope is obviously scope. It has become so synonymous with being doctors because we are able to, in real time, assess patients, listen to them breathing, auscultate, and make clinical diagnoses. And I would argue that the ultrasound is that new tool. It is something that the clinician should have by the bedside, be able to examine a patient and help them in the diagnosis. So I think that's everything I wanted to say. Don't know if there's anything else I wanted to say. But yes, so thank you very much for listening.
Dr. Abbasi, can you hear me? This is Tom.
Can you hear me? I,
Your,
I can.
your signal is in and out,
Tom,
but
I can hear you.
okay, great.
Can you
Well, that
can you
was spectacular. Will you make a promise to
Cool.
me to teach me how to say musculoskeletal properly when we're together in Atlanta? Well, it'll take a beer or two for me to be able to
Of
do it
course.
right, but I love the way you guys pronounce that. So I've got my trauma surgeon hat on now, and I want to ask you a couple of questions. So you showed us those beautiful images of rib fractures, and I assume that those are relatively acute. What in the US at least, we don't use that modality before we operate on someone. Do you get the opportunity to look at acute rib fractures before they go to surgery, or most of those patients you imaged, are they treated non-operatively? That's question number one. And the second question is, have you had an opportunity to follow the natural history of costal margin ruptures? I'm sure you've seen more than just the one example you gave there, but are those patients all going to surgery for early correction when you make that diagnosis, or are some of those patients treated non-operatively? And is that ever the right thing to do for a costal margin rupture, in your opinion?
Uh, Great questions. The first question is in terms of scanning. I don't work in a major trauma center, so that's the first thing to say. I think ultrasound in a trauma setting, certainly in the acute setting, is used as part of fast scanning. And I certainly would not be an advocate for saying that looking for rib fractures should be part of the primary survey. Most of the major trauma patients are going to go on to have CT anyway. So I would say that in the acute setting, it can be quite hard to scan patients, and I think it may not necessarily be the most appropriate thing to do, certainly in patients that have got polytrauma. I think ultrasound does perform superiorly to CT. I mean, most of the rib fractures you will see on CT anyway, and I don't think ultrasound will outperform in major polytrauma, but it will outperform CT, I believe, in costal margin injuries, and that is usually not, as far as I'm aware, the most pressing thing to fix at the moment in time. If they're very severely displaced, I suspect you would see them on CT anyway, but the more subtle costal margin injuries one might not necessarily pick up on CT. One would, I think that's where the ultrasound would fit in major trauma or acute trauma. Um, the second question, so I don't know if that answers the first question, or was there some other part to it? I'm not sure if
Yes,
I.
it does. I just was curious about in your experience, those patients that you evaluate and you see a costal margin. I'm sure those patients are sent to you by a thoracic surgeon. Do those patients all get fixed? And do you have an opportunity to scan them later to see if they evolve, or that was the question.
Yeah, sure. So, funnily enough, both of the case or the few, how many have I had? I haven't had a huge number of those cases, probably a handful. In all of those cases, these had become chronic injuries. They were all missed for months and months and months. And so they were presenting. The earliest case I can remember off the top of my head was about 24 months, but the other ones were missed for far, far longer than that. So I'm not sure. I think with the surgical element, I refer that to Ian and Joel and John Edwards about the optimal time. But presumably, when these become so chronic, certainly in the Ian's practice at that time was to manage them non-operatively in both cases because they had become so chronic that it seemed. I don't know. He didn't go on to operate on them.
Are there any other questions for Dr. Abbasi? There has to be some. Matt, you got a contemplative look on your face. You got something to ask him?
Yeah, a great talk. This was I've started to try and gain some skill at localizing fractures in the operating room. To me the most tachycardiogenic part of the case of fixing ribs is choosing your incision because you're always choosing a line of best fit. It's not like an anatomical incision you just make and then operate. And it really determines how hard or easy or how much you're going to struggle or how little you're going to struggle, the correct incision choice. And so I've been trying to gain some skill, but I've kind of limited myself to scanning using the probe perpendicular to the path of the rib, similar to what you would do on a fast scan, looking for lung sliding for pneumothorax. And a lot of the photos that you showed seem to indicate that you're orienting the probe parallel to the rib instead, and getting like a longitudinal picture. So that's a big learning point for me. That was very helpful.
No, actually, sorry, I showed the longitudinal picture only because most people will find that easier to interpret, but I would definitely scan the way you're doing it, which is perpendicular to the plane of the rib. That's a much faster and much more ergonomic way of scanning. I think if you scan perpendicular to the, or if you scan in parallel to the rib, you will traverse ribs very quickly without realizing. You'll go from the eighth to the ninth to the tenth, and you won't even know when that happened. It's very, very easy to do that because of the contour of the rib, and particularly in the setting of trauma, it become even harder. So I think the way you're doing it is definitely the right thing to do. I think one would then, once identified the cortical irregularity, then check in a second plane. That would be, that's the usual practice, is to look at everything in two planes. But yeah, no, certainly the way you're doing it is the way I would advocate.
Any other questions? Ali, I'm a bit surprised you didn't mention our foray into transatlantic dynamic ultrasound last week, and I'm going to put you on the spot here. Did you think that was there was any utility in that, or was it a complete stunt?
Um, Look, I think I think it was quite an interesting thing. So sorry, just to give you a bit of background. Tom and I speak quite regularly. Canton is actually one of my really good friends. He reached out to me and said, look, he'd had this patient that he thought may have slipping rib, and wondered if there was any way that we could do sort of a teleradiology scan of this patient, if I could guide Tom while he was performing the ultrasound. And I think for a first effort, it probably wasn't so bad. Normally, what I think, let's spin it around the other way. If you and I had had some time training face to face with ultrasound, and I was able to show you a reproducible, easy technique that one could perform, and then we were to do that scan, I think you would find that would be significantly more fruitful. I think just having some basic understanding of ultrasound physics, of how to play around with the machine and optimize it, and then setting it correctly, and then doing what we did last week, I think would probably be far more fruitful than just doing it off the cuff, out of the blue. Um, I think that's what I would say about
Yeah.
that. Yeah.
Well, that's great. And it's a segue into my next comment, which is we're going to do exactly that in the lab with a cadaver in a few weeks in Atlanta. Unfortunately, the lab is, Sarah, if you're still on, you can correct me if I'm wrong, but I think the lab is full, or if it's not full, we're almost full. But I agree with you. I think we need to look for creative ways to engage you and your expertise to make us all a bit smarter. I don't think you're going to turn any of us into a professional radiologist, but to be able to look at fractures and look at the costal margin, look for slipped rib. I think that's a skill that most of us could master with some practice and some expertise. Dr.
So
Erickson.
just
Oh,
to talk
sorry.
in, the advanced lab is full, but we have where we've set up a wait list. So if you are unable to get in, let me know. We already had one person on the wait list and then someone else canceled and we were able to move them in. So you never know. You may get in if you're trying to.
Thank you. Everett.
Yeah, hey, thank you for that talk. Really, really enjoyed it. Very interesting talk. Any tips or tricks on how to find the neurovascular bundle and differentiate it from the other tissue around it when you're trying to find that area at the edge of the rib cage and evaluate for the slipped rib?
So it really depends and it varies from person to person. There are some people where ultrasound is really beautiful. You get very, very high resolution images. So much of the scan is dependent on your tools. This is one of those scenarios where you can be a good workman and still blame your tool. The ultrasound machine varies enormously in quality. So when Tom showed me the machines he had available, the Sonosite type machines are just not very good. They're just not very good. So I wouldn't beat myself up if you don't get very good images from that. Um, and then, of course, patients who are slimmer, who have less body fat, you will get much higher resolution images. And in that scenario, one would see the intercostal neurovascular bundle. And I say it probably, I mean, I haven't got numbers off the top of my head, but I'd say probably in about 30 to 50% of patients, you would be able to see the intercostal neurovascular bundle really, really nicely. In other cases, if you can triangulate the anatomy from looking at the intercostal muscles and seeing the overlying, more superficial chest wall muscles, so you can get an idea of which plane you're in, then and also then being able to see the lung underneath, which you can see very well, the pleura, then one can infer where the intercostal neurovascular bundle is because anatomically it will lie between the innermost and the internal intercostal. So one would be able to find that. And the nerve, thankfully, when we're doing injections, does lie caudal to the margin of the rib. So when you do injections, you do avoid the vessels. And thankfully, I've not had a single bleed to date because the needle naturally, unless you're really poking it upwards, shouldn't hit the vessels.
Dr. Landcake, looks like you have your hand up.
Yes, so good morning. Ali, great presentation. I really enjoyed that. And looking at how well you're able to show the costochondral junction and those dislocations has me thinking about a treatment modality whereby, as you know, some of our colleagues do vertebroplasties by injecting cement into lumbar vertebrae in our older patients. Would it be possible, do you think, to inject something similar into some of those costochondral dislocations where, as you've beautifully illustrated, the discomfort is the movement as a treatment modality?
I don't know the answer to that question. I think talking about vertebroplasty though, using that as the example, the big problem with vertebroplasty is obviously leak of cement into the surrounding soft tissues. In the vertebra, that's less of an issue because the cortex of the vertebra is very thick. So it does contain the cement quite nicely. But when it does leak, it can be a real problem. The only thing my worry would be that if you're doing it, certainly in the context of trauma, how contained would you be able to, or how controlled could you be in where the cement ends up? Particularly if you're going to be doing it percutaneously, which is what I suspect that's what you're proposing, right? To do it percutaneously. So the percutaneous technique, the only thing that I think one would be more worried about would be that. One thing that did come to my mind, and obviously you guys are trauma surgeons, but I don't know how feasible this would be. But what about use of things like K-wires and so on? Would that be something that's feasible for these types of injuries, or is that a complete no-no?
Well, I guess I'm not an orthopedic surgeon, I don't use K-wires, but if you could, using your ultrasound, position them very carefully, and I'd be interested in what my colleagues think. And I mean, I'm thinking it wouldn't even necessarily need to be cement. Maybe we could develop something else that could help these things, stop moving. I was just admiring your beautiful images and thinking, if you've got something that will stop that moving, you may well just help the pain. So it'd be an interesting thought for people to muse over.
Mary, what about, you got me thinking here, what about stem cells or bone marrow aspirate or something that would be much more benign if it got into the wrong place? Maybe there's a role for that.
Yep. Some of that matrix that my maxillofacial guys use when they're, reconstructing jaws. Maybe we can. I've got an excellent plastic surgeon at work that does that. I might run it past him because, I think that would be quite an intriguing thing to consider, wouldn't it?
Yeah. Well, Ali, let me thank you for everyone that's here. It was very informative. great to get to know you a little better and to see your capabilities. And I look forward to future research efforts together. And Sarah, you might have an announcement or two for the group.
I do have just a couple. So I put information in about upcoming events in the chat. So please feel free to highlight those or make note of those and get registered. Next Wednesday, specifically, our next event is case review next Wednesday at 7 o'clock Mountain Time. So you can figure out what that looks like for your respective time zone. If you have a scientific presentation on the podium at the summit, the deadline for the peer review is Friday for manuscripts. So please feel free to send them my way. We will exchange them with the other the folks that are doing the peer reviews. That is voluntary, as a reminder, so you're not required to do it, although it is highly recommended because it gives you a good opportunity to have your manuscript reviewed in advance and get some feedback and make some changes before you launch into the JTAX process. The actual JTAX deadline is March 15th. So do not be late for that one. If you miss that, you're definitely out and you're going to be really bummed. So those are your upcoming deadlines. If you are planning to come to the summit and you have not yet registered, definitely do so. I know one of the nights, the hotel was randomly full for one of the nights of our room block as of this morning. And so they added a bunch more rooms. So if you tried to register for a room or you have tried and for some reason it blocked you out, go ahead and go back in and get your rooms booked because things are you're going to want to be there. Any other questions, Dr. White, that you can think of that I didn't address about the upcoming summit?
I don't think so. Do we need presenters for the for case series? Do we need somebody for next month?
We are full for February, but we have one opening in March.
Okay.
So if you are interested in presenting a case, March is your time, and then April is full. So you're looking far into the future if you're really looking to get something on and you miss your opportunity in March. So you may want to hurry. Oh, I know Dr. White mentioned that the course in Budapest. I know we have a handful of our European colleagues on board for this meeting. We are doing a partner course the day before the ESTS starts in May in Budapest. It is on our website. If you're interested in more information, you want to get involved and be part of it, or if you're not able to come the day before and you just want to say hi and have dinner while we're there at the ESTS, or get involved in the CWIS comings and goings during that meeting, certainly reach out and let's make time. So that would be great.
Just to be clear, the case review series for April is going to be at the summit.
Yes.
And we won't be broadcasting that live. So
we will not be broadcasting that.
You got to come to Atlanta if you want to be part of that.
Yes, you're going to, and it's going to be a special case review. So you are going to want to be there. If you didn't already have myriad reasons to be at the summit, we just gave you one more. So
Dr. Falix just put a message in that May is open for case review. Excellent.
So
all right. Well, my brain is full, and so I'm going to go try to do something that's less challenging than interpreting ultrasounds. But we're in your debt, Ali. Thank you so much.
Thank you.
Okay. Take care, everybody. Thank you.
Sally. Bye.
Bye.
Bye, guys. Have a great day.